I want to welcome everybody to the Transplant Institute lecture series, and thank you for joining us this afternoon. My name is Marwan Abuzoud, and I'm the Transplant Institute director. And it's our privilege today to welcome Dr. David Axelrod from Dartmouth-Hitchcock Medical Center. And Dr. Axelrod is an accomplished surgeon, investigator, and researcher as well, and is a good friend. And he had an excellent training background in this whole area of transplant outcomes research. His medical training started off at, let's see, you did at Duke Medical School, and you were the Duke M.B.A. dual degree, right? One of the early classes, M.D., M.B.A. Had prior to that gone to Harvard for a B.A., where also he's done some research, and his thesis was on relationships between for-profit agencies and non-for-profit hospitals, academic medical centers. So from the outset, had an interest in outcomes and finance, went to the University of Michigan for surgical residency and was Robert Wood Johnson clinical scholar at the time, studying health outcomes, and subsequently went to Northwestern for transplant surgery fellowship. Very extensive publication record and involvement with academic societies. His research focuses on outcomes and cost and value, now a new term. One of the great marks that David has made at the society level was developing leadership programs and chairing the business practice committee that helped facilitate a lot of understandings on costs and outcomes and training of healthcare professionals. He has led the leadership programs and now more recently the advanced leadership program for the ASTS, which has really made a great strides among transplant centers that's attended by transplant surgeons and administrators alike. And so today we're going to be focusing on assessment accountability, the challenges facing transplant professionals, give us some personal insight on what's going on around us. Thank you much, David. Appreciate it.
Well, it's a true pleasure to be here, and I'm grateful for Marwan because whatever the business practice committee has accomplished at the ASTS is because of what he did to start it. And you know, you guys know this stuff better than most, but hopefully we'll have a chance at the end to sort of think about some discussion on where we as a community need to go. For better or worse, we live a lot in this world of transplantation, trying to justify who we are and what we do to an incredibly growing number of stakeholders, including but not limited to our patients and other professionals and the payer communities and that sort of stuff. So we'll talk a little bit about how we're judged, why we're judged, and perhaps some suggestions about how we could be judged better. And then we'll end up with the real question, I think, which is, are we being judged on the things that we think are as important as people who actually take care of patients, and maybe we need to really drive that discussion forward. My disclosures, I'm an owner of a company called Zim Management, which actually you guys do some work with us. I'm not going to show you anything that the company does except to say that we actually try to think about these things and give people some tools to help with them. And all the tools that I talk about here are available free from SRTR and doesn't involve the company. So for CME reasons, here's the learning objectives. We'll talk about the limitations of the current methods of center performance. We'll talk about current and future methods. As most of you, I hope, know that they are changing the way that the program-specific reports, the reports that are available to the public, are going to be produced, the statistics that they're going to use, the way they're going to describe transplant performance, and we'll talk about where that is and kind of what's the good and bad parts about that. And then I think really we're going to sort of end up, maybe get Marwan to talk a little bit into CMO role about the implications of the shift to ACOs and, you know, as we recraft transplant care from just providing and putting in an organ to really thinking of ourselves as the master of end-stage organ failure from soup to nuts. So that's what I hope to accomplish. By the end, hopefully we can think about some key questions. One is really, do we have the current methods to accurately assess transplant performance? You know, are we really capturing what people are doing? The next questions are we rapidly enough communicating these performance metrics back to the people that have to make decisions? It really isn't terribly useful to tell you how you did in 4th grade when your kid's starting in high school. You really need to have these things in real time, and my argument for most of it is that the tools that are as they're currently constructed are retrospective, and so long ago they're almost meaningless. And then I think finally we'll talk about whether we're held to the right standard. So as familiar to most of this audience, we are the most regulated aspect of healthcare, probably, certainly in the country and probably in the world, that we are regulated by both our societies, our collective group, which is really UNOS, which is a membership organization, and by the payer communities, dominantly the Centers for Medicare and Medicaid Services in Washington, but a variety of others. And this really stems from legislation that was passed in the early 80s, which recognized a couple of things. First, that transplantation made use of a very limited resource, and where there's lots of rationing going on around healthcare, organ transplantation are the only population that really does it on a transparent basis with an objective set of criteria. I think lots of people do organ rationing on the basis of ability to pay or ability to access care. We try to do it at least on a transparent basis. And under this law, the National Organ Transplant Act, everybody who performs transplant, as you guys well know, submits data to the SRTR, the Scientific Registry of Transplant Recipients. And from this, we get a series of reports that are both used by our internal folks, which is UNOS. UNOS is a membership society that allocates the organs, as well as external reviewers, including CMS and the payer community. Principally, they produce these publicly available reports. They're called the program-specific reports, and they're available to track outcomes in 1 and 3 years. And around the world, this is seen as probably the best example of a database to track clinical outcomes anywhere. It's universal. It tracks people outcomes. It has real-time assessment of death through the death index. We have 100% data capture. Everybody else in medicine is trying to catch up to where transplant is today. And the question I think we have to answer is, well, is transplant today where we want to stay, or can we move forward to an even better place? It's used by a whole lot of people to determine things, most of which was never meant to be determined based on the data that was provided. So transplant assessment, as we were talking about, was really initially designed for quality improvement, and that we were going to use these data to improve the process of care by feeding back to individual transplant programs in a confidential way how their performance compared to other people's around, so that we could make sure that these limited number of organs that were actually available were being used in the best of all possible ways. It was really designed as a sophisticated M&M process and was supposed to have been protected. And that's really kind of how SRTR was and went along through its early years in the 80s into the 90s. And unfortunately, it was really the transplant community that didn't really make use of these data to deal with a series of bad actors that then got into the public domain. And once those sort of bad actors became recognized, we had centers that had vastly higher death rates than were appropriate. We had centers that weren't accepting organs because, oops, they didn't have any liver transplant surgeons on staff, and they forgot to tell their patients that. They had other centers that were, saying they were going to do kidney transplantation, and they had the skills to do it, but yet they turned down all the organs and that sort of stuff. Interestingly, all the examples that I just gave you, which are the ones that made the press, had nothing to do with what we're being judged on, which is what the 1 and 3 year post-transplant outcomes were for our patients, which is what all the rest of us answer to. It actually was mostly about what was happening to people on the waiting list, which we don't really talk about for some reason at the national level. And so now we use these data, which were really designed for peer review, for regulatory censure. We really want to know who the poorly performing centers are, and we sometimes threaten and cajole them, but really and truly, I think that there's a perception out there that they want to winnow the number of transplant programs down to a smaller number of higher volume programs. And I think that we have to ask whether the tools that were designed for peer review are the same tools that should be applied for regulatory censure. And if not, how do we need to tweak the system in such a way that we can do it? As I said, these were really initially confidential for peer review, and now they're publicly available. So this is the most recent stuff I could find for Ford. This is your waitlist mortality rates, which I think is really a credit to you guys. So here's what, the observed and expected looks really good, and the patient and graft survival rates. And this is impressive considering how competitive you guys are. And here's your observed to expected first-year survival for liver transplant. And just imagine what these data, look like to the rest of medicine when, you can, with the exception maybe of cardiac surgery, there's nothing else like this out there. I mean, you can't tell me how many people are walking comfortably with your hip replacement 2 years out from getting your hip replaced. There's a lot of good, cool advertisement about go to Cleveland Clinic or go to Sinai or go to this and go to that. But with the exception of a very small number of very highly specialized fields, of which we are the leaders, this kind of data doesn't really exist out there. But there's some huge problems with the current system, and problems that really aren't even going to get fixed with some of the modifications that I'm talking about. I think the biggest one is this issue about risk adjustment. And what does that mean? So we all recognize that the patients that we operate on and take care of differ systematically between centers, so that centers in New York and centers in New England and centers in California look different than centers in Tennessee and South Carolina with the patients they care of. Some of it is demographic, some of it is underlying disease process. A lot of it, because of how we distribute organs, has to do with severity of illness. And we know that people are getting transplanted at some significantly different severity of illnesses. The thing that differs between transplant and everything else is that it's not just a question of what the patients look like, it's what the donors look like too. And unlike, I have another sort of talk that I generally give to the more general surgery audiences, and I have a nice picture of, a cardiac valve, and you really think as a cardiac surgeon you would hope that every cardiac valve that you pull off the shelf is the same, and we all recognize that every liver we get isn't the same, and even the livers that we get that should be the same, that come from 25-year-old donors and everything else, it looks different if it's got 4 hours of cold time versus 12 hours of cold time, how it's come from and where it's come from. And so there's a tremendous amount of uncertainty, and yet we've got a system that's going to kick people out of the network, which is going to kick them out of being able to deliver care in their community based on a system which has a huge amount of noise in it. And how do we calculate that noise? Well, there's something called the C statistic, and the C statistic basically is kind of at a hand-waving level how much of this random noise is explained by your model. And it really works by saying if you have any two patients, can your model predict who's going to live longer than the other one? And if you had a coin flip where you don't know whether Marwan or I are going to live longer with a transplant, and we flip a coin, it's going to be right 50% of the time. So a C statistic of 0.5 tells you nothing better than a coin flip. A C statistic of 1.0 tells you that every single time that model is going to predict which person's going to live longer. So it turns out that if you look at the STS, which is the thoracic surgery group, model that predicts mortality after cardiac surgery, which is the most regimented, straightforward procedure you can possibly do. It's done in high volumes by very, very type 1 anal surgeons, so it should be all the same. The best you can probably do is around 0.76 for a surgical thing, maybe about 0.8. And we're kicking liver transplant programs out with a 0.6. Remember, 0.5 tells you nothing. So this is barely better than nothing in terms of explaining all of those complex stuff we talked about. Severity of illness, organ supply, organ quality, processes of care, and that sort of stuff. So we don't really do a very good job explaining the differences in the underlying patient populations that we care of. And then we tell you about your data 2.5 years ago, 3 years ago, 4 years ago. Thanks very much. And so the reports are episodic, time delayed, and statistically incorrect. So the current reports are 2.5-year cohorts. So they're 2.5 years worth of your transplants that were transplanted up to 3.5 years ago and take about 6 months to actually process. So essentially it's telling you how your son or daughter did in 8th grade as they're about to hit their senior year in high school, and you realize that they're actually not going to get into college and maybe they should go to technical school. I mean, it is that far in arrears, and yet you're actually trying to make decisions about where loved ones are supposed to go. You're kicking people in and out of networks. You're taking transplant leadership and changing it based on these very, very slow, inaccurate measures. And I think that we can and should do better. We have an economy where we're driving tech at rates that most of us can only imagine. I mean, already for 10 years, FedEx has been able to tell me how my package that started out in Thailand is going to get to my house in New Hampshire and on what day, and yet we can't figure out how to predict these things in better ways to give people better tools. And I'm going to argue that there are a couple of tools out there that are now slowly being adopted that will help with that. So there's two tools, one of which is a tool that I wholly endorse and have been writing about and talking about for a long time. And one is a tool that's going to be sort of pushed down our necks, but is probably a change for the better, but a lot of confusion. And so we'll talk about each of them. So for full disclosure, CUSUM analysis stuff that we're going to talk about second is the thing that I really think is really important, and we'll talk about it. And I think it actually provides you tools for program management for people who are actually trying to run their programs. It's rapid, it's sensitive to change, and by the way, it's available to everybody free on your SRTR website. And what's coming for the first time in July, you're going to see it on confidential release, and by next January, you're going to see it live, is something called Bayesian statistics. And so Bayesian statistics are a different kind of model through which we're going to report whether centers are better or worse than expected. The idea was that it was going to reduce the incidence of false positive flags, that we're going to do a better job of identifying who's in trouble and who's not. But the real issue, I think, is it's going to dramatically change the information that's available to us as program leaders and even more importantly to payers and to our patients. So what in the world is a Bayesian statistic? Anyone know what a Bayesian statistic is? So Bayesian statistics in a nutshell do a couple of things. The first thing is that it assumes what's called a prior belief. And so most of us remember, and I'll show you a bell curve, and that sort of old statistics basically assume that everybody exists on this sort of spectrum, and how they exist in that spectrum, sort of who's on which side of normal, is relatively equivalent and constant across everybody. And what the Bayesians said is, no, that's crazy. We all know that most centers are actually relatively good, and then there's this tail of centers that are probably pretty bad. And so why do we make the assumption that everybody fits into this normal distribution? And then we say that we have more information if you're a large center, if you've done a lot of transplants, about how well you're doing than we do if you're a small center and you've only done a few transplants. And so applying the same kind of statistics to the small centers that have only done a small centers, they're probably, in the absence of anything else, they look kind of like an average center. I mean, it's, you know, the bottom line is if you go to a sort of a normal restaurant and it looks clean and, you know, it's got a health certificate, the food's probably okay. You know, it's the same thing every time. That's your basic assumption. And it's only the sort of, you know, when you get a whole lot more information, you've been there a whole bunch of times, you've read a whole bunch of reviews, that you start to understand in depth how good that restaurant is. And so they say, unless you know anything else, you know, assume it's an Applebee's and maybe you'll be pleasantly surprised. And so that's really the sort of the difference is they assume that the distribution's not equivalent, and then they weight the assessments they come up with a little differently. So this is what we all sort of learned in, you know, whatever that statistics class you may or may not have slept through in high school or in college, that, you know, most of the people are in the middle, you know, and 2/3, and you get out to this, you know, p equals 0.05, you're out with these tails at about 5%. But that basically, if you look at the middle of the distribution, that half the programs are better than that and half the programs are worse than that. And that if you sample any sort of individual program, it will look like this. And if you actually look at what objectively the programs are doing across the country, it looks something like this. That if you look, here's a hazard ratio of 1. That means that a center is performing at average. And you can see that more of the peak here, that more of the programs are actually performing better than the average program than you would have in your other curve. But they're these sort of bad actor people who, you know, are way out in the tail. So that most people are reasonably a little better than sort of the average country, and then there's this tail that pulls the average out because they're not doing such a good job. And as I say, they take these two things and they do something different for large volume and small volume programs. If you're a large volume programs, you've got a lot of data because you've done a lot of transplants and you've been able to actually adjust for all those characteristics, even with using that crummy model we talked about. And so the report they're going to give you is really driven mostly by the data from your own program. And if you're a small program, you assume that they're about average unless you really have a lot of data that suggests that they're really terrible. And so for an average center, so this is a large center, you've done 300 transplants, of whom 13 died. You're only supposed to have 7. The observed to expected ratio is pretty easy. You divide 14 by 7, you get about a little less than 2. And you have a confidence interval, and you have a p-value that compares that to what would be a normal, to the normal average center. So this says that, you know, for this center, if you use the old statistics, that we would expect that their observed to expected ratio, they're about 80% worse than an average center. So you're 80% more likely to die. Now, remember, this is all relative. So if your overall graft survival rate is 90% in average, if you're 80% worse, it doesn't mean you're going to have 80% graft failure. It means you're going to have 18% graft failure and 82%. So sometimes people get confused when it says 80% worse. It doesn't mean 8 out of 10 graft fails. It just means it's a relative stuff. When you actually get the Bayesian output, it actually shows up as looking something like this. So it's not quite as bad as 1.87, because remember, we started out assuming that the shape of this curve was over here. But we see we moved from the average, I can go back one, less than 1 to a distribution that's more than 1, about 1.67. And we assume that if you resampled that exact center with those sorts of data a whole bunch of times, it's someplace between about 1 and 2.62. So that's sort of the noise in the system, that, all that stuff that we can't measure. It's about 1.67. If you're a small center, you've had 6 transplants, you've had 1 death. Right now, your observed to expected ratio, you had 1 death and you were expected to get about 0.18. Your observed to expected ratio right now is 5. That would imply that you're 5 times worse than everybody else out there. Now, everyone knows that, the reality is that, we're operating on human beings. Bad things happen. People have done the best job they can. You don't really know. That program may not be as good as other ones, but they're probably not 5 times worse than the national average. And so the Bayesians say, well, look, we don't know that much, so their curve looks, more like that initial curve that I showed you, a little bit shifted to the right. So we think we can say that within 95%, it's going between 0.28, which is 70% better than expected, and 3.31, which is 3 times worse than expected, and someplace in the middle is about 1.37. If you think this is confusing, I do too, and I think that we're about to push this out onto the community, and we're about to push it out to a whole lot of patients, and they're going to have to try to make sense of all of this. So this is what's coming down the hill. Why do people think this? Yes?
What assumptions are you making in the Bayesian model that gives them a break?
So what you're saying is you're going to combine this, which is if I know nothing about your center, if I know nothing about your restaurant, it tastes like an Applebee's, okay? It's probably not as bad as Jack in the Box, and it's certainly not a gourmet restaurant. We're just going to assume it's like the average. And the more times I've gone to the restaurant and eaten the food and had some more information, the more precise I can give you an estimate, and it will sort of reshape this curve. So the assumption is, one, that this distribution is actually right. This is what the SRTR thinks. Number 2, that that each observation is sort of equally weighted and everything else. 3, that we've even risk adjusted those observations properly. So it may be that 6 center is out, they're all doing 6 living donor kidney transplants on 25-year-olds with perfect kidneys. If they've lost 1, that's way out of line. Or is it they're doing 6 high-risk diabetics with DCDs, or if they've lost 1, they're doing okay, and we don't, we've got some risk adjustment in there, but it's very imprecise.
I mean, it just seems like that's actually saying that the real distribution is even harsher than what we're saying, because the true average hazard ratio is actually better than 1.
Yeah. So you're saying,
I would have thought that would make the small center's outcomes look even worse.
well, no, the small center, if you use the current SRTR data, you get an observed to expected of 5. What this one's going to report, you've got an observed to expected of about 1.4. So it makes it look way better than 5. And similarly, if you've got a center, that same center that in 6 transplants, nobody died, right now you've got an ODE of 0. You have the perfect center, which we know is also impossible. Now they'll report your ODE as about 0.9. So it's probably a little bit better than average, but it's certainly not perfect. But again, I think this is incredibly difficult for centers to interpret. And I think it's going to be hard for our patients to interpret. And by the way, with CMS, we have to give them the most recent MPSC stuff as they're sitting in their holding room waiting to go into their liver transplant. We're going to somehow have to explain this stuff to them. So, and maybe we're just going to have stars, and we have no data to be able to do 5 stars and everything else. So what does it do for a large center? It looks more and more like a real standard bell-shaped curve. For a small center, it looks more like that distribution sort of shifted here, there, and the other places. So this is coming down the line. The statisticians like this because assuming that this is what the programs look like, in a standard bell-shaped curve, is probably wrong, and it's statistically more proper to do the Bayesian stuff. I think the problem for people who are actually trying to make decisions off of it, either clinicians or patients and stuff, is that none of us have a familiarity. We don't really think in these kind of ideas. So one of the questions is, okay, well, I've just told you that this is your center, that your O to E is 1.67. Remember, I showed you guys, the O to E for Ford, and we know it's about 1. And so instead of giving you one number, I'm going to give you this shape. Now the question is, well, now that I have this shape, how do we know that a center is bad enough to be considered flagged and should get thrown out, or good enough to be thrown in? We have to come up with some flagging thresholds, and we'll talk about that. So in the current center, what we're really trying to ask with this flag is a particular center performing as expected? And we're going to give you a yes or no answer. So, within the best that we can assess, within 95% certainty, is that center a bad center or a good center? That's what we sort of answer right now. And if that O to E is 0.8 and you've got a 0.05, your p-value is significant, we would all say, given a 95% probability, that center is bad. And we all know that bad is such a loaded word, has all kinds of problems with it and everything else like that, but that's essentially what people are making the assumption is that center is bad. The new one says basically what's the probability that a particular center is underperforming. So instead of saying yes or no, we're saying, well, looking at it, there's like an 80% chance that it's bad. We don't really know. It could be like 75% chance it's bad. It could be 90% chance that it's bad. We don't know exactly, but we're going to give you kind of a rough estimate. We're going to give you a proportional likelihood that center is performing. So this is yes or no, it's bad to a 95% confidence. This is, here's the probability that it's bad, and we'll talk about that. So you're going to get flagged, one's going to get flagged if there is a 75% chance that that line that I showed you is at 1.25 or greater. Okay? Or there's a 10% chance that you're at 2.5 times or greater. So let's go through this, what this really means. So if your O to E that, in the middle of your thing is down here at 1 or below, you're golden. If your O to E is 1.25, you're on the cusp. If your O to E is way out here at 2, it's very likely that, given that distribution, that the real performance at your center is substantial. That's double the rate of failure that would be expected, and that you're probably not doing the right thing. So if there's at least a 75% chance that it's greater than 1.5, so this is 75% of the curve, this is 25% of the area under that curve. If it's over 1.25, you're going to be considered signal. If there's even a 10% chance that your distribution is over 2.5, so that's this area, this is 10%, that's 90%. If there's even a 10% that it's really that bad, then you're going to get flagged too. And it has to do with why they picked 2 thresholds. It has to do with big and small programs and kind of balancing and their simulation analysis and a whole bunch of other stuff. Again, I think for most of us who are used to living with, what's your O to E ratio? What's the O minus E, meaning how many observed to expected? What's the incremental number? Is it a reasonable number? It's going to be very hard to shift our thinking and to be able to interpret this stuff. And yet, come January, it's live. So what's it going to do? If you look at their numbers, there's a greater proportion of centers that will actually get flagged. Even though they said there were going to be less, the way it's currently constructed, there's actually more centers that are going to get flagged, and there are more centers that are small and medium-sized programs. It will take fewer graft failures and deaths to get flagged prior to it. So not only are we going to flag more centers, we're going to flag centers at sort of a tighter threshold. So, instead of having to, if you do 100 livers, you need to have 10 deaths to get flagged now, or 12. You're only going to need to get 9, and it has to do with the way that these statistics are created. So it's more centers will get flagged, and the centers that get flagged are probably going to get flagged at lower numbers. So it's going to, I think, overall make everybody much more conservative. It's, I think, less predictable for centers in general, because you can't sort of plug it into sort of standard equations and figure it out. You have to know how to interpret the areas under those curves, what the shape of those curves are, how the models are going to adjust from year to year to year to year to year, to have a really good understanding of how much trouble that you're in. And it's unclear how patients and payers are going to interpret the data. And at least the last set of guidance that came out from CMS is CMS has thrown up their hands and said, we're going to stick with the old way. So at least for the next set of reports, well, patients and the community and the public reporting is all going to be this Bayesian stuff. CMS is going to recalculate based on the old stuff and say they're going to use ODE and 0.5. Sir?
Can you give me a feel for how far back we'll go with this model?
2.5-year cohorts, standard cohorts and stuff. All that's changing is, so you're going to have observed, that's the easy one, we count deaths. We're going to have expected, that's based on the model that we talked about, at least in liver, with a C statistic of about 0.67, 0.7. So all the noise in that. And then how you compare those two things, whether you just put them into a standard bell-shaped curve or whether you put them into this model, that's what's changing. And what's changing is how you're going to signal and on what basis you're going to signal. What I think you need to know from running a program is it's going to get tighter, especially in moderate-sized programs. You're going to have to be more conservative rather than less conservative. And yet again, we've basically, I think in many ways, magnified the problems that we already had. Why are they choosing to do this? Because it's probably a statistically more accurate way, and it may be that after they first sort of put this in, they'll tweak those signaling thresholds and go back to something a little more normal. Yes, ma'am?
I'm sorry, I may have said this. So in the models, they're going to account for, can you talk about the variables at the beginning, about
Yeah.
variables in the sense of extended criteria donor,
Yep.
they're going to account for these variables with the new distribution curve in the model, but then on middle and small programs that do 6 or 7, how are they accounting for power? I mean,
Right.
you're saying the confidence interval is going to get wider, but they're going to get more conservative.
Right. So, so what's going to happen is, for really small programs like 6 or 10 or 12, there will actually, for very, very, very small programs, they'll be less likely to signal doing this, and so the MPSC basically is going to still use the old thresholds, which any small volume program, which is anything less than 10 over 2.5 years, will get reviewed if you have even one event. And so when you look at that, so very, very small volume programs are unlikely to get, will probably be, are sort of still treated as outliers and will be still signaling, at the same rate. It's the sort of 30 to sort of 50 a year kind of programs, certainly 30 to 50 kidneys a year, maybe 20 to 40, 45 livers a year program, 50 livers a year programs. If you're at 100, 120, 130, it's not going to look that much different because you can see that curve looks more similar to what it is. It's probably going to, it does sort of shift it in a little bit, but if you actually look at the centers that get signaled, they will signal more centers will get signaled, and the centers that are likely to get signaled change. So in the old system, because if you're looking at, you've got a lot of numbers, you have a lot of power, it's likely you're going to have a statistically significant p-value. So large programs are more likely to signal. In the new system, that goes away, and you have these distributions, but it's those programs in the middle where you didn't have enough numbers to get to a p less than 0.05, so they weren't signaling in the past, even though their ODE was over 1.5. That they're now going to signal because they're using these new methodologies, and they're not improving the risk adjustment at all. Nope, risk adjustment's the same. So observed and expected are still calculated. It's just whether that's a statistically significant difference is changing. So what would I like to see as someone who runs it? I would like to see something that is actually timely, that actually helps me run my program, that's easily interpretable, that I can actually explain to an audience and have it make sense, that's sensitive to clusters of failure. I think it matters as a surgeon. If I've lost the last 3 graphs that I've put in, something's probably wrong. If I've lost 3 graphs over the past year, that's a different problem. And clusters of failures often represent changes in technique, or Marwan hired some new surgeon out of nowhere, and all of a sudden he can't sew in the kidney. Sorry, boss. Yeah, I know. Or the nephrologists keep forgetting to give them their immunosuppression. Something's changed if you have clusters of failures. That's risk adjusted as best we can, and is clinically relevant and useful. And there is a tool, and it's called CUSUM. And CUSUM has actually been around since the 70s. at least in healthcare, even before that in industrial processes. And it was one of these things that we would keep measuring the output of a single machine. And if eventually you would get those measurements high enough that it would be out of spec, and then you'd go and fix your machine and it would produce your widget again. And people said, well, wouldn't it be nice to be able to do that in healthcare, and couldn't we do that? And there was actually a series of papers that were published, one in JAMA, one in the New England Journal in the early 70s, and there were two problems. One was they didn't have the statistical computing power at the time. You know, there were only a few computers around. And the other thing is they didn't really have enough data to be able to do risk adjustment right. So it kind of got shelved. And lack of risk adjustment and need computational power. And then there was a guy named Steiner that sort of started in the sort of late 90s looking at this idea in cardiac surgery. And he incorporated a huge amount of risk, he incorporated all the new statistical programs and risk adjustment and said, gee, we can actually use that. And then when I was finishing my residency in Ann Arbor and doing my fellowship, we wrote a couple of papers on how to use this in transplantation. And so what is a CUSUM chart and why would you even want one? Well, it's a graphical representation of outcomes care process. It's risk adjusted for important donor and recipient characteristics. And you can plot these outcomes over time so you can really compare the results with a national average. So again, it's still giving you sort of the observed to expected idea that we've all been talking about this morning. You know, how are you doing compared to what your national group is? But it doesn't do it in an episodic way. It does it in a continuous way. It does it all the time, real adjustments. And I'll show you there are a couple of types of them, and it depends on how you read them. But the important thing is that it trends the plot line over time to really help you figure out whether your outcomes are getting worse or getting better. And you can see it very easily. And if you're a program that's kind of going off course, your chart's going to go one way. And if you're a program that has done what Marwan's done, invested a lot in processes and really thought about your care and really organized your systems of care, you're going to see it getting better, and you're going to see it getting better in real time. So this is an actual CUSUM plot. This is a one-sided CUSUM chart. And what a one-sided CUSUM plot really means is you don't get credit for good performance. So you'll see it's stuck at 0. And every time this program is going along, and then they have a graph failure. So you went from 0 to something a little less than 1. And the reason you went for something a little less than 1 is that there's a risk adjustment in there. So instead of just counting every graph failure the same, if you lose that young live donor kidney that should really do well, that might even be a little bit more than 1. Whereas if you lose the kidney on that 73-year-old diabetic DCD kidney, that maybe only counts for 0.6 or something on your CUSUM, because it's much more likely that you're going to lose that, so it doesn't count against you. And then as you go along in time, it starts to head back towards 0 because you've transplanted more things and people less in these graphs haven't failed. So you can see if the process is going along okay, you have a failure, do you do okay? You do a failure, you do okay? You know, along in here, there's really nothing wrong. The process, everybody has failures, nobody's perfect, but it doesn't start to sort of accumulate. But yet, if you start to have a lot of failures in a row, so here, starting here, there's 1, there's 2, there's another one, they do a little better, 1, 2, 3. This is a real program, by the way, 4, 5, 6. There's a cluster of failures all in a rapid sequence, and that suggests that there is something going on in that process of care that needs to be looked at. Does it mean that they are a bad program? The answer to that is clearly no. It means something ought to be looked at, you know, and it may be, you know, it was bad luck, and bad luck happens, and you know, and that sort of stuff. But if it's my program, I'd like to know this so that I can decide if it's bad luck or it's bad practice or if there's something I can fix. So what you need to know is if it goes up, it's bad, and if it goes down, it's good. So here's a two-sided chart. So you do get credit for good behavior, and you would interpret it slightly differently, but the same concept is okay. So if it's going bad, this is the program that's starting to get in trouble, and then it said, uh-oh, you know, we need to actually do a better job. And then you see from there, rapidly that program got better. So bad, good. Here's the relative risk. So if you're at a relative risk, it's looking at the slope down here, that's relative risk compared to what is expected of less than 0.5. You're doing really well. Relative risk of 2, you're not doing so hot. Does that all make sense? It's just a little more explanatory. So we did some retrospective stuff way back when. We actually basically constructed CUSUM charts looking historically and compared them to what the MPSC actually found. We did a whole bunch of kidneys and livers and that sort of stuff. and we basically adjusted them so that you'd have about the same false positive rate that you had in the MPSC method. And what we found is if you took a facility doing about 100 kidney transplants a year, there were 17 of those in the country. 3 of them got flagged by the SRTR under their old methods. It took them 3.5 years to flag them. 3 of them got flagged by our methods, same number, same centers, but it only took 3/4 of a year. So it's a center that it's a method to rapidly pick up on changes in performance that allows you to act on them. So we said to the SRTR way back when, can't we do this for everybody? And we actually did this pilot project when it was still at Michigan, and a bunch of liver programs got it around the time when we were pushing a lot of DCDs and everyone liked it. And then the SRTR moved and it got kind of dropped. And about 6 months or a year ago, it got reintroduced, and it's now on your confidential website. So this is a real CUSUM thing. So you see here, this is a two-sided. So this is a program that's doing well. It's doing well because down is good. You had 2 graft failures, doing well, had a graft failure, doing well. But you can see, if you look at the sort of overall trend line, this is a program that's actually getting better over time, or at least it's certainly not getting worse. And you can pull these up, I think they're updated at least monthly at this point for free. Yes?
Is there an expectation that a program should remain some level of consistency of doing well, or constantly in the improvement phase? And if you're going to constantly go up but then come down,
Right.
then objectively that's not necessarily
Right.
a steady state of acceptability.
Right. So I think that's a great question. So what do you expect? I think that there are these 2 charts we showed you. One's called the observed minus expected chart, and one's this one-sided chart. And the way that I think about them, the one-sided charts, the ones that don't give you credit for bad performance or for good performance, are the ones that I think are the ones that you should look at to say, is my program in trouble today? It doesn't sort of give you as much of an idea of time trend over time, but here's a center. So those 2 graft failures, you go back down to 0 graft failures. If this line stays, low, you know that even though there's, some blips up and down, you're basically not in trouble. And you have this line up here. If this thing starts to get up here, it's in trouble. So in answer to your question, it is clearly an expectation that you will always stay under that line. However, as a program, this is going to probably oscillate a little bit depending on sort of how aggressive you are. This sort of tells me, that we changed some things, or the program, or this isn't ours, but we changed some things, and it looks better now, and everything else like that. It sort of tells you kind of a gestalt how the program is sort of doing over time, and there's an expectation that at least you're sort of going around the midline here. If you're going down consistently, that's great. That's but there is a ceiling effect. We can only get 100% graft survival at the most. And reality is, given who we transport, I think we're already at 93, 94% in kidneys, and close to 90% in livers around the country. And one of the reasons you're seeing centers getting flagged is that all the centers are so keyed into post-transplant outcomes that they are becoming, I think, more and more conservative about who they're actually transplanting, and that the outcomes are actually getting better and better and better. And as a result, centers that look like they were doing okay over time are actually, if they haven't kept up with this continual process, it's like the economy and that sort of stuff.
And fundamentally, this is a process control chart.
It is.
Right? And that's, I think, goes to the question that if this is a process control, it's supposed to kind of tell you what is variability and what counts as variability and what doesn't count on, and what counts and looks as a real trend versus spurious variability. And this is why when we say the patient died from a car accident, you get a blip, but they're going to flag a program for a car accident. But if you have many events, a lot of mortality, it's unlikely you had many car accidents. You got something serious.
Right.
And that's the value, I think. And think of it as a process control that's telling you when that variability is meaningful versus not as meaningful.
Right, and if you have 5 guys who get hit with car accidents all at one time, then I think you ask your social workers, why are we not looking at the high-risk behavior that our patients are doing, and that sort of stuff. So if you have the ascertainment of past performance, we really want to identify high and low performing centers, use that for regulatory oversight, selections of center of excellence. You really want high reliability, which we haven't gotten to, low false positive and false negative, accurate assessment of both improvements and decline. And what they're trying to do is to try to get better with the PSRs. These are always going to be episodic, and they're always going to be time delayed. Whereas if you really want to have data to drive your program, you need something continuous, as Marwan was just talking about, which are the CUSUMs. So we've just talked a lot about these first two questions. Are we done at 5, Marwan?
Yes.
Or a little after? So I'm going to run relatively quickly. So we just talked about this. But the next question, I think, which is really the more important one, is really, are we held to the right performance metrics? So we just spent a lot of time talking about how we're going to be judged. And we haven't even decided if we really are held to the right performance metrics and who are we really accountable for, and then a little bit of what are these unintended consequences. So when you think about accountable care and transplant, we've been spending a whole lot of time talking about one metric, which is survival. We're talking about post-transplant survival of grafts and patients. We haven't talked at all about cost, which I think is really important from the rest of my work. We haven't talked at all about value, which if you're a payer is really what you would like to know, which is kind of how much is it going to cost me to get live patients out of your center with or without transplant at X, 3 years, 4 years, and everything else like that. And the other question is that we've only talked about that we're accountable for the people that we've actually transplanted. Most of us recognize that at least we've made an ethical obligation to the patients we put on our waiting list, which says we're going to make our best faith effort to actually get you a transplant because you think that you're going to live longer with a transplant than without one. We might actually say, which is what I think we're hearing, is that there's a whole bunch of patients who were evaluated who may or may not have the sophistication to know that if they come to a program in Ohio and not get listed, that they could come to Henry Ford and get listed. So there's an evaluated patients. At least if you tell them you're not going to list them, that patient who's come through your evaluation can go get care someplace else if they're sophisticated enough. And there actually may be a whole bunch of people with organ failure who don't even know that transplant exists out there. We know that there are people who are showing up, with these large HCCs, that if they'd only known that they had cirrhosis, that they could get transplanted, would have gotten transplanted before they ever got cancer, and they would actually be there. So I think that one of the things that we've really concentrated on is which of these populations are we willing to be accountable for and get judged on. So, the current PSRs, I think, really focus on the wrong metric, post-transplant survival. It's the metric that Medicare outcome citations are based on, and there are no penalties for increased pre-transplant mortality. So if you got a lot of people dying on your list, even though all the examples of the people that I talked about at the beginning that led to transparency of this data were about pre-transplant metrics, there isn't any penalties for it right now. And so it's human nature to focus on the measured outcome. So the system right now is not designed to maximize transplant benefit. It's not designed to maximize the amount of patients that are getting it transplanted or even the best use of those organs over the long run. It's really designed to minimize post-transplant morbidity and mortality. And so does it matter? We did some work looking at least at liver transplant. We know that around the country that there's significant diversity in waiting times between transplant regions. So if you look at how many people will get transplanted within 90 days in a region, if you're in California, well less than 50% of them are being transplanted within 90 days. And this is in a system of allocation, for those of you who don't do liver, that has nothing to do with waiting time. So the sickest person in the region gets transplanted next. So you don't have to wait for 2, 3, 4 years. But yet less than 50% get transplanted. And if you go down to see my friend Jim Easton in Tennessee, 75% of those patients are transplanted within 90 days. So there's this huge disparity in the number of people who get transplanted quickly. And we could show average MELD score transplant, all these other metrics of it. Interestingly, there really are no barriers to travel between regions for patients. So we don't let organs out of region 3 without prying them out of people's cold dead hands or whatever the guys on the gun with the gun lobby say. But patients who've got money can fly. And so there's this natural experiment that shows how much of an effect being aggressive with the patients on your waiting list can have an effect on their overall survival. So we looked at it. We defined somebody who traveled as somebody who basically moved from one region where they were listed, they delisted and transferred to a different center. Basically, they went someplace where they thought they weren't going to get transplanted because the waiting times were too long and the MELD scores were too high, and they figured out that they could go to another region and get relisted, and get transplanted more quickly. And then we looked at their demographic characteristics, and as you can expect, the higher your socioeconomic status is, the smarter, the more access to resources you have, the more likely you are to travel. So that if you look at people who are on the list by 5 years, it's about twice as many people who are rich compared to who are poor. And you could plot the same thing with race, ethnicity, and surprise, surprise, the Caucasians tend to end up on the top, and the African Americans and some of the other minorities end up on the bottom. So we've created this system that basically allows an internal system of transplant tourism. If you got money, you can travel, and there are people who are trying to capitalize on that. So does it matter? I mean, does it matter just how much getting transplanted faster? Can you basically buy life? And the answer is of course. So we match these people who traveled to people who stayed behind in their old regions, matched for all the things you'd want to match on: age, gender, diagnosis, that stuff. And we looked, and we saw that, not surprisingly, if you traveled, there was a significant increase in the number of people who got transplanted, and they got transplanted faster. And if you looked at overall survival, the patients who traveled, had a significant improvement in survival, and those curves keep spreading. So as you go out of time. So the bottom line is that if you aggressively transplant people off your waiting list, you decrease overall mortality, even including the fact that these curves look pretty similar up here, because even though they get transplanted faster, at some point there is a cost of transplantation. There's a death rate associated with transplantation. So it matters what you do on the wait list. And so then the next question is, well, why just stop at waitlisted patients? We know that that there are a whole lot of patients out there that may have been evaluated for transplant and turned down, and can we even think about that? So all the previous analyses have been based on political boundaries. Everything about regional variation is based on OPOs and states and stuff like that. But that really has nothing to do with patients. And these are all analyses about where the organs go in organ procurement organizations and regions, not where patients come from. And so we thought to try to figure out can we define regions in this country that define where patients actually travel to get care, and then look at the variation in care based on patient travel regions. And so we needed to have a population of the accountable population that was served by that transplant center. Can you figure out under which counties Ford serves predominantly versus U of M versus Beaumont versus other people like that. And so we did a whole bunch of stuff, and we'll show you. We used UNOS data and this Dartmouth Atlas of Healthcare, which breaks down the country into something called hospital service areas, and we linked them all together. And so this is where I live. This is a hospital service area. Each of these little counties is assigned to our hospital based on old Medicare claims. We look at where most people got their care. So we have these little HSAs, and there's a ton of them across the country. And then we took each HSA and we said, okay, of all the people in the HSA who got listed for transplant, where did the majority of them go and actually get listed or get their transplants? And then we could bring it out. So this is New England. So this is Maine's catchment area. This is ours in Dartmouth. Some of the Boston programs, because they're all so tightly packed, you can't really tell them apart. But that's sort of Bay State. That's UMass. It's probably Albany, something like that. That's University of Vermont's area. We clustered together transplants that were within 10 miles, and the HSA were designed on where most of the patients were listed, and this just came out. So this is the transplant referral region map of all the kidney transplants in the country. So you can see you guys, here's probably Lansing. You guys are probably lumped into U of M because you were close and that sort of stuff. Here's Madison's huge big catchment area versus Milwaukee versus Chicago and that sort of stuff. There are about 133 of these regions. About half of them had more than one transplant center. About 60 to 70% of the patients who were living in that thing actually got transplanted at the places that we thought them, which is, for the guys who do this, they tell me that's actually pretty good. And we saw there was huge variation in access to care. So the listing rates, so we actually know, because these are dialysis patients, so we know everybody who's on dialysis in the country, how many of those patients who would be potential transplant candidates actually got listed. It varied by about 500%, so 7.7 to 32. The mortality rates varied less, but about 50%. And importantly, listing rate, so getting on a transplant list, even if you never got transplanted, was strongly associated with reduced chance of dying from your end-stage renal disease. So the higher the listing rate, the lower the rate of deaths. So, and we could do this. And I was going to say, you guys get it. Here's your the transplant rate here. Here's what was observed, and here's what was expected. So you guys transplant people faster, and you lift the right amount. So in the end of the day, all the stuff we talked about at the beginning assumes that we're only accountable for transplanted patients. I think we've at least shown with the liver stuff that we need to be accountable for the people that we put on our wait list. We've made a commitment to them. We've said we're going to transplant them. We need to figure out how the systems of care are to make them healthy. And the SRTR and other people have said, yes, if you put them on your wait list, you are increasingly responsible for them. And people say, well, yeah, but they're being cared for by their local community hospital. Well, then we got to figure out some set of care to get them in there. And as these big accountable care models come around, we're going to show you if you can keep them healthier, on your wait list, you're going to reduce the overall cost of care. So at least probably going to be accountable for the waitlisted patients. It might be necessary at some point to sort of look at listing practices. And I'm not sure you want to hold centers accountable for it in the sense that you punish them, but I think that you at least want to look at what these metrics are doing to the overall level of conservatism around listing patients. And I think that you're going to see that there are a lot of patients who are probably very viable candidates for transplant, but because centers are so concerned about their post-transplant outcomes, they're never making it onto the waiting list. And being part of a transplant program, even if you don't get transplanted, generally tends to improve care and that sort of stuff. And then there's this huge populations of patients with end-stage organ failure that we don't even touch. And maybe we ought to really say to those centers, what are you doing to reach out to those dialysis centers? How are you getting out there to talk to people with liver disease, to get them to know that they need to get care, they need to get their HCC screened, they need to get their Hep C treated. So as we focus on population metrics, we're going to focus on the population of end-stage organ failure, not simply on post-transplant patients. And I think that changes us from transplant programs to places that serve end-stage organ failure centers, which really is what we do. We're multidisciplinary, we're continuity of care, we're the things that we're where accountable care needs to go in this country. And we need broader systems to track and improve care from diagnosis to definitive therapy. So we become accountable providers of end-stage organ failure, as I say, and not just transplant programs. So at the end, we talked about whether the current methods accurately assess transplant performance. My answer is no. Are they rapid enough? Well, we have the answer. CUSUM's there. It's available to everybody, and I think it's better. Are we held to the right metrics? Right now, I think the answer is, again, we're held to a metric. It's better than almost anything else out there, but it's not as good as it could be, and I think we need to think about a broader population that we're accountable for, and we need to think about the consequences of the current methodology. So I think I summarized all that stuff. So with that, I will be happy to answer any questions, and I appreciate the discussion as we went through. It makes it much more fun. Sir.
My question is that transplant is very much a silo.
Mm-hmm.
Only people who really care about, in my estimation, organ failure are the people who treat them, surgeons and or the medical doctors. If you're going to expand the interest in the wait list, the evaluating patients, and the patients with organ failure, how do you suggest making that a priority for the hospital or hospital system when we serve so little people as opposed to the people with hypertension?
Well, I think that it's a really important question. And how do you raise what's a sort of niche service to a high profile across the institution? Clearly, the one thing that most administrators respond to is money. And even though there are not tons of them, organ failure patients tend to be incredibly expensive. They account for a huge amount of readmissions. They account for a significant amount of staff resources. And as we go from providers of healthcare to being really insurers, which is what the accountable care we're going to be at risk for those patients. They're going to be, they're going to be people that have a substantial impact on the bottom line. So that's point one, I think, is they're smaller number but very high cost. The second thing is it's clearly a very high profile service, and I think that what makes particularly academic centers or sort of high-end tertiary quaternary care centers like Ford different from good community hospitals. There aren't a lot of things. There aren't a lot of service lines. There's lots of good cardiac surgery that goes on in the community. There's lots of good neurosurgery that goes on in the community. One of the things that sort of becomes a sine qua non for our kind of care is transplantation and end-stage organ failure. And if you are trying to set up a healthcare network, either you need to have somebody who can provide that care inside your network, or it becomes a service line that you can turn around and sell to somebody else. So if you put together a network of primary care doctors, at some point somebody in that primary care group is going to need a transplant. And either you provide it yourself or you have to come to Ford. So you think you go to Ford and you say, look, we have this program that actually not only serves our ACO, but will probably serve 3 or 4 other ACOs around. And they're going to go, well, what's the value of that ACO? Well, you start out with good post-transplant outcomes. That's just sort of that's the barrier to entry. If you can't have good outcomes, you're nowhere. But then you say, well, look, we do a really good job from soup to nuts, and we can treat their HCCs early, and we get them involved in Hep C treatment, and they have less recurrences, and we keep them out of the hospital with their encephalopathy, and we can facilitate your fistula first, and we get them live donors, and we start to think about the penumbra of things that are around what we're doing. I think it becomes something that becomes much more attractive to them. And then I think the final thing is that it actually attracts a lot of people to other high-level care in your hospital. The people who if you get a transplant someplace, you tend to stay for your knees and your hips and your heart and that sort of stuff. And it's not true for actually other stuff. You can get your aorta fixed, and the answer is most people don't go back to the hospital where they get their aorta fixed and get their ankle fixed. But they always come back for their transplant. So those are the things that I think I try to sell anyway.
How do you figure the attribution is going to work out when you think of population management and you start mixing community hospitals, academic hospitals, transplant centers? How are you going to mix that attribution on the outcome?
Yeah, I think it's an interesting question. I think the first step of that again will be these accountable care organizations where we sort of patients are explicitly assigned to us, and then we as sort of providers of this, at the top of this pyramid, have to sort of go out into the community and sort of try to organize care. And I think they're going to be attributed on the basis of the plurality of their overall healthcare needs, which I think comes back to the point we just made. I mean, how are we going to, is it really my responsibility as a transplant surgeon based on the fact that some guy has rheumatoid arthritis and has come to my hospital a bunch of times for that? That said, I think the attribution is going to be difficult. Clearly, I think the first step is the waitlisted patients, and I think we sort of move in a systematic way, and we say, at least the patients who are on our wait list, we've said to them explicitly, we have a responsibility to you. And so we can be accountable for that. As you go beyond that, I think you start looking at these underlying care issues and things like that. It becomes more difficult.
Yeah, one of the things that Medicare and other payers had difficulty with attributions.
Right.
And they started using formulas like if somebody has been seen by a primary care so many times per year, the attribution goes to that person. And we found that many of our patients here who were attributed to us actually were seen by other primary care physicians outside the system more often. Right. And yet the attribution came to us because they were actually booked under us. So the outcome was attributed to us and the cost of care, yet we didn't really provide the care.
Right.
Because patients were given choices that they can still go see Doc A, Doc B, Doc Z for whatever reason they wanted.
I think the accountable care stuff is a mess right now, and I think you're exactly right. I think transplant is better because at least we know who our population is. We can close the window. And we know that our contracts are going to increasingly include some of those costs too. Well, thank you guys for taking your time to come. I really appreciate it.